I've got the graveyard slot and everyone's staring at the wine now. So.
No, we don't
Help yourselves to a glass of wine. I'm slightly out of sync, I think, because I'm going to really talk about things with a slightly more UK perspective, but I'm going to talk about what I do in terms of grubbing around in London. But I'm going to finish with, I think, what really fits in quite well in terms of, looking back in terms of sort of lessons of history that we've seen. That was a fascinating look back at the history of pharma and development of antimicrobials. But one of the things I was asked to reflect on was, quite simply, what's the difference between TB and HIV? And I did quite a lot of work with people who work in BBVs, did a lot of Hep C work, quite a bit of HIV work, and they've got a really easy job. They just wander around with a nice big bag of clean works and dish out a few condoms, and they've got some nice sensible public health messages, and then they go home. My public health messages invariably don't breathe, so I have to take a slightly different approach to try and sort of think about the control of diseases, because I'm dealing with an airborne disease and the choice agenda has just been removed. I think that's quite an important point, and one that we really don't stress enough when we're talking about TB and the human rights dimensions of TB. Ibrahim mentioned something that we've probably all seen in the papers in recent years, and that's London TB capital of Western Europe. Well, let's just put that in context. These are all the big capital cities in Western Europe with a population of more than 500,000. And these are the numbers of TB cases reported by these cities. And if you add them all up, from these 13 cities, there's more TB cases in London every year than there are in the rest of the 13 put together, the rest of the 12 put together. And people think, well, that sounds pretty bad. Yeah, but it's all about Eastern Europe, isn't it? So let's do the same sort of principle for Eastern Europe. Let's take this idea of a capital city with a population of more than 0.5 million. Let's stick them on the map, and lo and behold, we've got more cases of TB in London every year than you have in all these Eastern European capital cities. And Ibrahim stuck this graph up earlier, but I stuck another line in it just to try and reinforce the sort of global position that London plays in Europe and in the world. Nearly 40% of all the cases in England are in this city. That's a staggering portion of the disease. As has been alluded to, the rates of disease vary enormously from one area to the next. This is mid-superalpha areas, and as you can see, we've got quite a few areas here with an incidence of more than 180 per 100,000. This is a staggering incidence of disease. As you can see, using some more sophisticated mapping tools. It very simply illustrates a rather powerful correlation between disease and social opportunity. Poverty is really the enduring feature of TB today, and it always has been. Let's look at the epidemiology, which is to a certain extent, the surveillance of the disease is to a certain extent masked and sort of compounded and confounded our understanding of it in some ways, because it's got this real unhelpful and unusual fascination with origin and ethnicity. And nationally we sort of fit the kind of 80-20 rule. If you want facts, if you want some real information on this issue, you won't go wrong really on the Mail Online. It didn't take me long to pull this together, and I won't read it to you. But the reality is, we did this piece of work a few years ago, and this piece of work really underpinned the kind of thinking that went into developing the surveillance system to extend beyond age, sex, origin, ethnicity, site of disease, to try and build a deeper understanding of the social context of TB, the risk factors. We were late to the table here. The Dutch and many other sensible countries have been collecting information on imprisonment, on homelessness and drug and alcohol use, etc. for many, many years. But this was a prevalence survey. About 95% of the patients on treatment were included in this survey. It was a really good uptake. And over 2,000 cases, big slice. And lo and behold, what we found was the rates are actually highest, if we exclude HIV, unsurprisingly, the rates are actually highest in homeless people, drug users and prisoners. And the rates in the sort of usual suspects, in inverted commas, i.e. the foreign population, the recent migrants here, sort of paled into insignificance. But there was something more worrying going on. This relatively small proportion of the whole which on this prevalent sample was 17% of all cases, they were massively punching above their weight in public health terms. And they included a good proportion of all the infectious cases and half of all the infectious drug-resistant cases. Add to that, there was a higher risk of delay to diagnosis, there was a higher risk of being lost to follow-up, etc. And as Ibrahim said, and the data is clear now in terms of factors like homelessness correlating very well to transmission, when we look at that lens of the molecular epidemiology of this disease. But more recently, when we look at the last 3 years' worth of data in London, because we've only got 3 years' worth of data with social risk factors, homelessness is an independent risk factor for MDR-TB in London, after you adjust for age, sex, ethnicity, origin, etc. So it's on the map. It's scary. So once we've sort of got over our rather unhealthy and unusual fascination with origin and ethnicity, and we want to actually try and think in terms of the disease and how to actually control it, we ended up with this concept of a proportion of the whole who were hard to reach. I like the term. I mean, it's really the services that are hard to reach. I think people are moving more towards medically underserved, aren't they? But that just keeps getting misspelled as medically undeserved, which is not for either. But you know, we are in a growth industry, luckily. As the economy dives, you know, our work has really picked up. You know, obviously the funding's gone, but you know, we're lucky. You know, things are looking good for the future. Yeah, when you talk about the sort of homelessness that we're seeing in London now, people are really being pushed to the periphery. We're seeing a lot of people who are really under the wire. They just don't exist in terms of statistics. Most of the change in terms of our work in the last sort of 24, 36 months has been a movement away from building-based services to street-based services. And in terms of the centre of London, I don't know if you've seen that rather beautiful map that Michael Marmot's team produced. It says this is affordable housing today, and this is affordable housing in 2015. But basically, they've ethnically cleansed, in inverted commas, the core of the city. And it's just pushing people who are excluded to the periphery of the city, and where we end up screening in car parks behind wicks and really wonderful church halls, because it's the faith-based organisations that are actually stepping up and filling the gap now, because there is a significant funding gap. In terms of the arrest rate in the population we work with, it's quite staggering. There's 300,000 notifiable arrests in London every year, and that includes somebody going into a cell, a holding unit. I've visited all of them. None of them have got a window, let alone any kind of ventilation. They vent it from one cell into the next and into a communal area. So unravelling the sort of transmission dynamics of this disease is a challenge. But you know, quite simply, what I've done is try to build a service that's taken this pathogen out of the household setting. You know, when I get TB, I'm going to infect everybody I'm ever going to infect in the first couple of weeks. They can be invited into services, I'll get my diagnosis, start my treatment, and contact tracing will close the loop. Contact tracing is, you know, the way we close the loop. It's the public health intervention that supposedly closes the loop. I'll take that TB bug and I'll unleash it in a crack house. Yep. People don't know who their contacts are. If they did, they don't want to tell me. If they do tell me, I can't find them. If I can find them, they tell me where to go. So the whole essence of control, i.e. public health response to an infectious case, broken down. And you know, the pathogen's found its niche. The constellation of these risk factors lead to quite explosive change in transmission. Now in the next 3 X-rays, I could have chosen hundreds of different series, but I'll give you this one. We started screening on the street with digital mobile X-ray way back in 2005. This guy hops on the van, he's fit and healthy, and NAD there and then on the spot, 90 seconds of your time, thank you very much. You keep your eye on this area, you pick him up again, 18 months later, he's in HMP at Her Majesty's pleasure. He's got these nice little preclinical opacities. Get the bug out of him, he's got iron resistant TB, but he's a remand prisoner, he's not a sentence prisoner. At this time we're just driving around London with a van, finding lots of people with TB and sending them to services, trying to get them into services. And lo and behold, he goes to court, there's no onward care organised, and he's released into the community. 18 months again later, there's bugs in this man now, so a year and a half later, you pick him up, he's moribund in an A&E unit, and his favourite hobby is smoking enormous quantities of rock cocaine in a very confined airspace, where everybody's coughing their guts up and no one's saying, "What's the smoking there? Should we open the windows?" So the chain of transmission between this image and this image would have probably bought me a new van. So the reality is, we needed to take a more proactive approach. So we built the idea of find a treat off the back of the first service, which was called Find and Lose, which wasn't so good. And we now screen about 10,000 people a year, nearly 300 different sessions, loads of different community third sector partners. We find a lot of our own work, but we also take referrals from every single service in London and increasingly further afield. At the moment on the books, a third of the cases are working. We've got drug-resistant TB, 70 MDRs and 6 XDRs. So in the last 3 XDRs, one recently had an MI, the consequence of the treatment. One's had an entire lung surgically removed. We're back to that kind of resection approach. And one newly diagnosed 18-year-old girl has got bilateral disease and is disseminated. It's abdominal as well. We're planning how to isolate her until death. I mean, this is heavy duty, isn't it? This is not good old TB with, ironically, lots of short course treatment. Another thing we do a lot of is, I mean, formally, as Ibrahim alluded to, we've got about 5% LFU rate in this country, which is far too high. And you know, formally, before we came along, you know, if you disengage with services, you know, I would write a very stern letter to your park bench, and if you failed to respond and come in for your appointment, you'd be written off, bye-bye. But we actively go out and relocate people now. And depending on your sort of priority in terms of your public health threat, that can be a bit Orwellian. We work with police, we work with probation services, we work with prison service, we work with the NHS Student Tracing Service, many other databases to find people and signpost. But what usually nails it is the good old shoe leather work and actually flagging with agencies who are on the street and will look for people for us. But you know, really the icing on the cake of the service for me is the fact that we've got engagement with the third sector. I mean, the NHS seems to be really bad at working with the NHS, but it's terrible at working with the third sector. It just doesn't do it. And they are our partners. I mean, these are the people who support DOT. These are the people who are looking for the symptoms. These are the people who will accompany people to appointments. And the front end of the service is former patients. And I mean, back to the future then. So here we are, 1960. In the 60s, we're in Glasgow. This is the national fleet assembled. Obviously, as prevalence declined in the population, it became non-cost effective to do mass mobile radiography. So we junked the entire service, we scrapped it. Not so many other countries. This is a Dutch fleet today. They just targeted it. There's no such thing as a perfect test. I mean, the test will perform well if you target it well. If there's a high prevalence of the condition you're looking for in the population, it will work. So let's just have a look at how it works. Well, how do we get you on the van in the first place? Well, the first thing we do is when we engage with a local community, whether it be a building-based service or a street population, we need these guys. These guys are the front end of the service. They've all had TB, they've all experienced homelessness, and most of them experienced serious addiction issues, etc. And they are the authentic voice. They can really take the message to the street. Because there's a huge amount of stigma, and people just don't want to engage with the idea of TB. You know, a lot of people we work with have got quite a few pack years under their belt, and they don't want to know they've got cancer. But our sort of mantra is, give us 90 seconds for a bit of peace of mind. And these guys can do it. This intervention, in terms of peer intervention, works. I won't dwell on this for too long, but it also seems to be quite profoundly beneficial for them. It's a really quite powerful means of supporting recovery. But the process itself is not rocket science. We've just taken an old technology and dragged it kicking and screaming into the 21st century. And because we can read it on the spot, that means we can actually have a conversation with the person. It dramatically improves the sort of diagnostic accuracy, but it also opens the door to a range of other health interventions. Many around respiratory health. Unfortunately, we work with a population who are really good at they use an enormous amount of drugs, but they're not very good at taking drugs, the irony. But a lot of them smoke rock cocaine, and a lot of them have got emphysematous changes in their late 20s and 30s, and their lungs are on a one-way ticket to bye-bye oxygen. They've got no insight into that whatsoever. And so the kind of respiratory, building a better respiratory health intervention around radiology is a fantastic opportunity. But we read and report on the spot, and we give people the diagnosis on the spot. Anybody got any idea what's wrong with this guy? He's got rather bad TB and he's full of 12 gauge pellets, but he was actually aware of the fact that someone had shot him. So about 80,000 chest x-rays so far, about 1% have got query-active disease. From that, it's about, PPV is about 0.23, so 1 in 4 of the referrals that we make start treatment. That's a good test, the right test, the right population. But 2% of them have got all fibrotic lesions. And if we were to go to the States with these all fibrotic lesions, they would take a rather more serious approach to actually managing all fibrotic lesions. Most of them haven't got any treatment history, and you know, there's a bug in there in many of these instances, and we're seeing them starting to come back. There's two sort of missing opportunities in the service as it stands at the moment, both of which we're trying to address. One is all fibrotic lesions, and two is people who are at the younger end of the market and co-infected and quantiferon LTBI positive. But overall, you know, this is a case-finding rate. This is a difficult rate to understand. This is the rate of undetected active pulmonary disease that we find on the street. Amongst homeless people, it's about 230. Amongst prisons, it's about 215. That's just pulmonary TB not known to service. That's a staggering amount of TB. Because we target it well, and because we use a simple classification system, and I think most importantly because we have the right set of eyes, we actually have demonstrated quite a staggering sensitivity and specificity. It's almost kind of rewriting the book in terms of the diagnostic accuracy of radiology. But we need to go further, and we're currently doing an RCT with this little beauty, which many of you will recognise as the Cepheid gene expert, and getting it onto the street has been hard work. It's not a particularly robust piece of kit, and we like to shake things quite a lot and give them a good kicking. But the main problem has been trying to actually get around some of the regulations around specimens. I mean, you can spit any way you like. No one really gives a monkey, but as soon as you put anything in a pot, you know, all hell lets loose. So we've had to use these rather nice little sample pots, which they've got a septum on them. So I collect the specimen in my perfectly safe negative pressure environment, which is called the pavement. I can introduce the reagent and give it a good shake, 6-fold log kill. 15 minutes later, it's a safe specimen to handle on the van. So we have permission to actually do diagnostics on the street. From the point of view, if it's positive predictive value, obviously useful, but its negative predictive value is fantastic as well. I mean, if you're negative on this platform with a good sample, the chances of you transmitting TB to anybody is extremely low. It doesn't say you're not going to be culture positive and we're going to follow you up with culture, but I can leave you in a custodial environment, or I can leave you in a hostel. If you're on the street, fair enough, I'll take you in full stop, but it's really reducing the numbers of people that we've had to actually make an enormous amount of effort to try and get into hospital until they've got smears. But that's the easy bit. Getting people through treatment is the real challenge. And I'll just share with you a couple of the recent things we're doing. We've had to open a hostel for TB patients because we just lost people. It's completely unrealistic to expect somebody on the street to be able to manage a TB treatment. Some people are on 50 tablets a day. This place is really specifically for Eastern European men, many of whom have got what we call no recourse to public funds. They're legally entitled to remain, but they have no entitlement to any kind of assistance whatsoever. So they get a free carry bag full of pills, but there's no food, there's nowhere to stay, and it doesn't work. We had poor outcomes prior to opening this hostel. Since we've opened this hostel, there's been about 14 guys through, including 7 MDRs and 1 XDR through this hostel so far. We haven't lost anybody, and we've massively reduced the arrest rate and the use of A&E services, etc. When you kind of factor it in, you know, just if you look at it beyond just an NHS model, it's hugely cost saving. But there's a slight snag because it doesn't exist. It's not legally allowed to exist. if the local authority found out that this place existed, they would close it down because they would say it would give the people in it right to say they had a local area connection and therefore they were entitled to some sort of support. And no one will fund it, because again it comes down to this idea of, that's a social care intervention, we're a health service, so I have to go somewhere else. Oh, you've got no recourse to public funds. Try the pavement. It doesn't work. Getting enormous quantities of medication inside people is a challenge. We use every trick in the book. If you're not on methadone to start with, if you're not opiate addicted, we always try and get people onto methadone. No, we don't. The drug, in terms of big pharma, if you really want to crack it, you need to develop a TB drug regimen that's slightly more addictive than crystal meth, and then we'd know. But we're doing a randomised control trial at the moment with smartphones using internet technologies and handheld technologies, and it's incredibly promising. It's not only enabling us to keep track of patients, but it's also enabling them to really build it around their lives. People doing it on the bus, people doing it at work, people doing it wherever. Do it wherever you like. And increasingly it's giving us an opportunity to interact with people on a real-time basis. And I'm an old fart, but most people are very comfortable with these technologies, and particularly a lot of our younger patients, they already have a device, so it's just a case of actually installing an app, etc. on their phone and setting them up. It's almost cost neutral. So what's the impact? Well, early detection prevents future cases, and we've been independently evaluated twice, once by HPA and more recently by NICE, and both of those evaluations have demonstrated that we're not only cost effective, they were probably cost saving. And neither of those evaluations took into consideration future cases averted, and neither of those evaluations took into consideration the fact that if we find you on the van, our mission is to basically employ you. So getting people off the street and into work has got quite significant cost benefits as well. So without taking that into consideration, we're already cost effective. And 84% of the people we find on that van complete treatment. Nationally, 82.9. So yes, you can get people through treatment. We've got a high death rate as well. It's highly cost effective, but it's unfundable. We've never had more than 12 months' money, and haven't been paid for last year, and I don't know if I'm going to get paid for next year. And the reason why it seems to be unfundable is because it doesn't fit anyone's footprint. It's a pan-London service and a national service, and it's a health and social care intervention. And most of the team are non-clinical. We're adding value. One of the ways we're adding value is by, getting back to the people not pathogens mantra, is by trying to build a service that's really around their comorbidities. And there's some phenomenal opportunities to actually take diagnostics to the street here. I mean, these truly are 21st century technologies. This thing, it's called a multiplo. This is Hep C, Hep B, HIV in about 3 minutes with really good sensitivity and specificity for one blood spot. We want to start using this. We've started doing a lot of work to actually measure and estimate the prevalence of this of co-infection in the population we work with, and it's staggeringly high. I slightly skipped over. I won't read it to you. But flu, classic example, 60% of the cases that we work with are already eligible for influenza vaccination due to a pre-existing clinical risk criteria. Do they get it? No. If you look at pneumococcal disease, if you look at the American data, I think it's about 1 in 4 of all deaths following a respiratory admission are associated with invasive pneumococcal disease in our population. Do we use this vaccine? No. When we did the big bleed, over 1,000 people, 60% had no immunity to Hep B. 60%. This is after supposedly throwing a lot of vaccine at our population for many years. And I think it highlights something that's quite important. We're reaching an invisible population. They're not using building-based services, many of them. They are under the wire, and if we don't take healthcare to them, they don't get any. It's as simple as that. And most importantly, we're slightly doing them a disservice by just driving around irradiating them. We've got to provide a service that really reflects their needs. And increasingly, this is the clinic. This is where we need to work. This is knee-deep in needles. And if we can take an intervention to the street that's fast, and we can actually engage with people through a peer intervention, we get a really high positive uptake of screening. People want to know. And contrary to some of the advice we receive from particularly HIV physicians, people want everything at once. They just want it one hit. If I'm going to make a hole in you, I'm going to test you for 4 things. If I can just do it from 1 blood spot, great, 3 things. I mean, this is the elephant in the room in terms of Hep C. Most of the people that we work with who've got Hep C have not actually got access to testing until they've been engaged with a drug treatment service. And you don't get into a drug treatment service for having a can of cider and 2 splits. Most of them have got between 7 and 9 years of pretty hardcore Class A drug use before they get into a drug treatment service. Force of infection for Hep C would say that most of them acquired their disease in the first 12 to 18 months. Yep. So if we're going to make any population impact, we've got to get testing further upstream. Similarly, if we're going to actually get any benefit from the new Hep C drugs that are coming online, which are fantastic, we have 12-week regimens for genotype 1 and 3 with good clearance rates, that's £1,000 a pop. I mean, they're going to have a serious think about adherence and a social support service. They've got to address the determinants of disease. And that's really what I want to kind of finish with, the social determinants of disease. This is my favourite anti-contagionist. This is Herman Perdue, and he believed that TB amongst the poor was caused by external poverty, forces of overwork, poor nutrition, etc., etc. But in order to explain why TB affected all strata of society, he also explained the fact that TB was caused by internal poverty, and that was the poverty of the rich, and the rich got TB due to flabbiness, excesses at table, and the torment of ambition. And in 1867, he was that close to, it started in 1867, by about 1880, 1882 nearly, he was that close to getting a fully funded national association of local associations to remedy the causes of TB. And the entire mandate of those associations was to, number 1, improve childhood nutrition, number 2, address the quality of housing, particularly remove all these stupid taxes around windows, so everyone boarded up their windows, etc. And number 3, improve the working conditions of children and the poor. And really, Herman's mission, Herman's thesis was that TB was really framed within this paradigm of the state having a responsibility to improve the lot, i.e. the masses, and in doing so their health. And he was just about to get his check when along came this man, which is really why we're all here, World TB Day, next Monday, March 24th, and Koch brilliantly demonstrated Koch's postulates that it's an infectious disease. And this completely shifted the emphasis away from this concept of the state's responsibility to protect its people to a completely linear biomedical paradigm, which is we're still living with today, which is the physician's responsibility to kill the bacilli. We don't use a traditional definition of cure. There isn't really a definition of cure for TB. There's no test to say you're cured. You're cured if you've taken X amount of pills, have no symptoms, and I can't get a live organism out of it. That's as good as it gets. But if I'm picking people out of the gutter, irradiating them, if I'm going to just stick there and put 6 months worth of pills inside them and then gently pop them back in the gutter, are they cured? No, they're not cured. So we have to build a social determinants model in terms of moving forward, in terms of the E word keeps cropping up, eradication. If we're going to think realistically about eradication in any way, we're going to have a bigger think about these two paradigms. We need to find a way for them to coexist in the modern world, because currently this one was totally superseded by this one, and we're stuck. The drugs pipeline is a really fascinating story, isn't it? The 4 drugs that we have in the frontline regimen were all invented within this tiny period of time. But again, let's look at it in context. If we think about the introduction of the first sort of effective treatments and take it to modern times, only 5% of the decline in death rate associated with TB can be attributed to the introduction of effective treatment. Only 5%. Yeah? So, again, these two paradigms need to coexist. And I'll finish with this rather brilliant comment, which you can read yourselves. And I think it's certainly a good opportunity for debate. And thank you very much.